Hi, I'm Lauren Griessmeyer. I'm the Willow and Beaker Practice Director at Nordic, and I'm here today with Karen Hahn, who's one of our consultants out in California. Karen, why don't you tell us a little bit about your background?
Well, I've been a nurse for going on 15 years now. I started off as a clinician in a med-surg tele-unit and quickly got absorbed into the clinical informatics role in the hospital side. And then my organization decided to embark on an electronic health record project. So I quickly became a part of that and was ClinDoc certified in 2006 with Epic. And then worked on various implementations, probably about 10 or 11 with that same client.
Wow.
Yeah, at different hospitals.
Number of rollouts.
Mm-hmm. Small, large, teaching hospitals across the board.
So you've seen it with ClinDoc.
I have, yeah. Okay. So in 2011, decided to become a consultant and see some other organizations and loved it. And then quickly took roles related to meaningful use.
Okay.
So I've been doing the EH side of meaningful use at a couple of institutions now. And
what does EH stand for, just for the newbies that we have out to this meaningful use conversation?
Sure. So eligible hospital is also known as EH. Meaningful use has two sides of the coin. EP for eligible providers is more the ambulatory clinical side, and then EH is more the hospital or large institution side of meaningful use.
And does that dovetail with the community access hospital, or are those kind of two separate buckets?
They're two separate buckets, but depending on how their build is, they could be wrapped up into the eligible hospital side.
Okay.
So that's always something that organizations need to keep in mind
as they're doing their project plan.
Correct.
Gotcha.
Yep. So I've been at this client now since October, and I was brought in as the ClinDoc, Stork, and ASAP team lead, but also responsible for the eligible hospital build and configuration for meaningful use. That
sounds like a pretty full plate.
It very much is.
Yeah.
Some days, it's a balancing act, and but I enjoy, I work with a lot of great people on multiple teams, and then also I get to deal with the eligible professional side too, a little bit. So it's nice crossover between the teams.
Cool. Can you talk to me a little bit about some of the patient engagement strategies that you're using on the inpatient side and some of the tools you use to accomplish patient engagement?
Sure thing. So one of the main strategies that eligible hospitals really take into consideration and use heavily is the after visit summary. Mm-hmm. So when a patient is discharged from the hospital, they get kind of a summary of their care while they were in this hospital. So the after visit summary is also available in the MyChart application, so that the patient, when they get home, can also access that information electronically through MyChart. So they don't have to rely on that piece of paper, or what happens if I spill my coffee on it, or they can always get to it electronically, and it has a lot of great information for the patient. Follow-up appointments, it has follow-up, go see your PCP in 2 weeks, or maybe some wound care instructions. So that's really one of the main strategies that the EH side uses for patient engagement.
Okay.
For meaningful use.
And is that one of the main tools you also see for transitions of care when somebody's going from a hospital to, say, like an outpatient recovery sort of a scenario?
Yes, absolutely. So we can give an after visit summary to those different levels of care, the different facilities that the patient may be going to next. We also have a tool called Care Everywhere in Epic that allows those facilities to actually enter a patient's record and see kind of what happened during the course of the stay. So a couple of different ways that we can provide communication so that level of care stays pretty standard for the patient.
Okay. So we've talked a little bit about some of the tools that you can use on the inpatient side for patient engagement for meaningful use. Let's talk a little bit about some of the barriers you run into during a meaningful use project on the inpatient side.
So I think one of the major drawbacks to meaningful use is sometimes CMS makes regulations and maybe doesn't take the considerations of a workflow in mind. So they, of course, just publish all these standards, and it's really up to the organization to fit them into their standard workflows for the clinicians. And that's probably one of the biggest areas I see organizations struggle with, is getting those standards into their workflows so that it's intuitive and it's just part of their daily workflow.
Can you give me some examples of particularly tricky regulations that you've seen organizations incorporate into a workflow successfully?
So one of the main themes with meaningful use is getting those providers to enter a problem list, or keeping that problem list accurate and up to date. So a lot of facilities struggle with getting physicians on board with just entering a simple problem. You know, they come in for maybe a chief complaint, and then getting that attending provider to really update the patient's problem list so that it really accurately reflects why the patient's here. So I've seen some organizations develop best practice advisories to help physicians as more reminders. You know, just, hey, update that problem list, review it for accuracy. And that's probably one of the ways I've seen organizations succeed in meeting that one particular measure related to the problem list.
So you've been involved in a number of meaningful use projects, and you've had some involvement of actually doing the project planning as well. Can you talk a little bit about the strategies that you've used to keep these meaningful use projects on time, on budget, and successful?
Sure. So I've seen organizations succeed when they have a group that's designed with multiple applications involved and committed to getting the work done. The resources have to be planned and accounted for, and there has to be clear guidelines on when timelines need to be completed. It's also important to have a governance structure made up of clinicians, partly, that understand their current workflows, as well as that are empowered to make decisions.
About what the future state's going to look like?
Right. So maybe a change in the workflow. Should we do it this way or this way? And really having a strong commitment from leadership with that governance group to give them the authority and the autonomy to make decisions is one of the areas that I think facilities struggle with a lot, but I've seen organizations succeed if they do have that really strong governance group that can make those kinds of decisions.
I think that the project that you're currently on is working on stage 2, is that correct?
They are on stage 2. They're reporting on stage 2 currently. They're in planning stages for stage 3.
That's pretty exciting.
It is.
So can you talk a little bit about the trickiest piece for stage 2 that you guys have run into currently just on the inpatient side?
Well, I think transition to care is always the area that a lot of facilities struggle with. I know just meeting some of the thresholds is difficult.
Can you talk a little bit about why that's so hard? What is it? Is it the workflow? Is it the technology? Is it a combination of both?
Yeah, I think it's a combination of both. So you're involving clinicians that have to enter certain things in the record, as well as getting the system to set up configuration behind the scenes that sends a summary of care, for example, to a PCP. So having all of those pieces work together, as well as provider records all have to be configured, and when you have a lot of providers that you have to touch each one, you know, it gets cumbersome and time consuming. So I think that's an area that a lot of facilities struggle with, and especially the client I'm at right now.
Just because of the number of working pieces.
It's complex.
Yeah.
For sure.
Okay. And as you guys are ramping up for stage 3 and you're thinking through the guidelines that have recently been published and are commenting back on them, what are the areas that you are really focusing on and putting some real thought around? Well, how are we going to manage to do this piece?
Sure. So for the EH side, there's a couple of areas for my current client that we're really starting to put some thought into, and that one is e-prescribe. So my current client does not use e-prescribing functionality on the hospital side. They use it on the EP side. So that's going to be a big change for the users, not only in their workflow, but we also have some technical build behind the scenes that has to occur.
So we've talked a bit about the tools that you guys have been using to achieve some of the goals of meaningful use, but one of the big goals of meaningful use we haven't talked about yet are improved patient outcomes. So let's talk a little bit about the improved patient outcomes that you've seen as a result from meaningful use.
Okay, so really the outcome is pretty much a standard of care that benefits the patient. You know, the patient is ultimately the reason why we're doing all of this.
Right.
So I've seen really good outcomes when the clinician is provided a clinical decision support tool at the time of order entry, for example. The patient's on a particular medication and the physician or provider is prompted to order a platelet count, for example.
It's like a safety check.
Right. So again, you know, the electronic health record can provide a lot of different tools and that benefit the patient ultimately. I've seen some documentation prompts that a nurse can use. For example, we just built a best practice advisory for the nurse to put on sequential compression stockings if the patient had an order and hadn't been documented on.
Okay.
So we just built a BPA to help the nurse. She probably already has put the device on the patient, but just a reminder to document that in the record. So all of that care basically just ultimately benefits the patient in the end.
So we've talked about meaningful use, we've talked about improved patient outcomes. Let's talk a little bit about clinician engagement. So that can sometimes be a little bit of a tricky topic.
Sure.
As you've been talking about, you know, a lot of the tools there are set up to increase documentation. They're not going to take the place of clinical decision making. It's just more of a reminder to put that information into the system. What strategies have you guys used to increase the use of the system tools and increase clinician satisfaction and engagement with the system?
We've used a couple of different strategies, everything from getting the clinicians engaged in the workflow up front, where they think the best place in their normal documentation would be, which flow sheet do they want to document that in. Everywhere from that initial clinician involvement to the reporting end. At the end of the whole workflow, we want to see where maybe the workflow didn't work out quite so well. So
right.
Epic has some really good tools for showing where those pieces of the workflow maybe broke down. And so getting those clinicians to really see those trends and run those reports, routinely kind of helps them become engaged and involved in getting perhaps better numbers and better outcomes.
Get involved a little bit with the system optimization, which is a buzzword that you're
right.
hearing a lot within
right.
the Epic space.